For those of you who are joining us, I want to let you know that the University of Victoria is situated on the traditional territories of the Lekwungen and Wasanich peoples, and we acknowledge and respect the Lekwungen, which is the Songhees and Kapusan peoples on whose territory the university stands, and the Lekwungen and Wasanich peoples whose historical relationships with the land continue to this day. I'm really excited. We have an exciting speaker from the University of Colorado here today. So Dr. DeCamp is going to talk to us a little bit about chatbots in healthcare and give us the practical side in terms of thinking about patients in the interactions we have in healthcare.
Well, thanks again for this opportunity. It's a real pleasure to be with all of you and to talk about patient-facing chatbots in healthcare. I am a practicing general practitioner. I'm also a philosopher. That's where my PhD background is. And I do some research, as you'll soon learn, on patient perspectives on the use of chatbots in healthcare. And like I said, I'll try to go quickly through slides with the hope that we have more time for Q&A, because I think there's probably a lot of questions in this very fast moving field. These are just some disclosures about where my research is funded from. I don't have any financial conflicts of interest related to companies or AI tech companies. And I just want to note that anytime I mention a product today, it's really for illustration and certainly not meant to be any kind of an endorsement. I hope that by the end of this brief presentation, you'll be able to explain both the potential and the perils of patient-facing chatbots in healthcare, as well as analyze some of the ethics tensions that I see arising in their use, things like tensions between choice and manipulation, between access and stigma, and even more. And I'll close with a final section really about the future of these technologies and where I see some technologies going, and in fact, in some ways already are compared to when I thought about these slides just last week. So let's start just by introducing the idea of patient-facing chatbots. And in fact, in some ways, this is not altogether new. I'm going to show you a couple examples of early phase chatbots. We've been developing things like technologies like virtual therapists for a long time. So in some ways, chatbots aren't entirely new, although recent tech developments in LLMs and other technologies, of course, have made them more powerful, as we'll see. So on the left here is a chatbot known as the Genetic Information Assistant, or GIA. This is a published chatbot that actually is capable of giving genetic and genomic test results. Think of it like genetic counseling. Some of you may have heard of a chatbot known as Wobot. Wobot was a mental health therapy chatbot. It was used for counseling and various other purposes. And one of the things that the company that developed Wobot touted was actually that human users of Wobot would develop human-like bonds with the chatbot within only 3 to 5 days of use, already highlighting an ethics question, right? Should that be the goal of developing those kinds of bonds, or should we think of it differently? But in fact, chatbots go back even further in time. And this is ELIZA. And if you look closely at the citations on this slide, you'll see that ELIZA was a chatbot type platform developed back in 1966. And if you look at some of the interactions that are on this slide, some of the quotations back and forth, it actually sounds not too different than some of today's chatbots, but this was a very early version of this attempt to mimic human conversation through the use of chatbots. So not altogether new, even though I think we all recognize that they're a lot more prominent now. And why is that? Well, we all recognize that many of these new technologies, whether it's ChatGPT, Llama, Claude, Perplexity, and so many more, these have rapidly catalyzed the idea of patient-facing chatbots, in part by being publicly available 24/7, and they're general use chatbots, as I'll make a note about in just a brief moment. You can see on the right this picture claiming that every day millions of people are asking ChatGPT for support with their health in various ways. So plenty of people already using these publicly available chatbots. So much so that look on the left, that chatbot Wobot I mentioned to you was actually shut down, in part because the thinking behind this was that it was in part because the use of ChatGPT and other type technologies were making older chatbots like Wobot now obsolete, rapidly changing field. I mentioned this fork in the road, and it's important when I get to our own research study. There is a distinction between narrow chatbots on the one hand and general chatbots on the other. So think of narrow chatbots as being those that are designed for specific tasks, like GIA, like delivering genetic test results, whereas general chatbots are capable of a wide range of tasks. They can do lots of different things. And as you can readily see from what I showed about ChatGPT already, that's a general chatbot. You can ask it lots of different types of questions. You can use it for mental health support. You can ask it questions about medical test results and so much more. And a lot of the excitement today really is around this idea of a general chatbot for patients. And imagine the promise of a technology like this one if we do it well. I've already mentioned 24/7 access, but also no geographic mobility or transportation barriers to a patient who needs to interact with a particular chatbot. In some studies, chatbot responses are perceived as more empathetic than human responses. A big asterisk there because I think you need to look carefully at these studies, scrutinize the methods to make sure that they're rigorous and well done. But in any case, you've probably heard the idea that responses from an LLM can be perceived as more empathetic in a form of mimicry. Chatbots can be efficient for the use of time and resources. They could be used for patient reminders, for preventive care, for medication adherence, and so on. Because chatbots can real-time translate, they help language access. We actually have a research project ongoing now where we use an LLM on mobile devices to be able to real-time interpret Arabic for us, Arabic writing. No small feat, an amazing technology to have for our research. Chatbots don't get burned out, and so much more. So lots of potential for technologies like this one. This is a poignant example of how a chatbot can be used. Liz Salmi, who's a colleague and a collaborator on some of our other projects, is a patient who's had a history of brain cancer. And if you read this story that she wrote for the popular media, you can see that Liz uploaded her entire 4,800 plus page PDF medical record to create a new LLM that she called Kaiser GPT that she could then query within those 4,000 pages and get summaries of what had happened over time with her medical care by sharing first, and then developing this LLM. Liz also connected two separate patient portals, so two separate health systems, each with their own patient portal, connected those to ChatGPT Health, again allowing her to query multiple records in ways that are still a problem with the lack of sharing and lack of interoperability we sometimes see in electronic health records. Well, Liz used ChatGPT to bridge that gap. Lots of interesting questions here you can already imagine about privacy, ownership, control over data, and so much more, but clearly a lot of potential for LLMs like this one. But there's also the peril. There's a famous story, infamous story, I should say, tragic story here in the US about an individual, a teenager who committed suicide. And this has resulted in legal proceedings because the teenager had been interacting with ChatGPT over time in the weeks, months before the suicide. And they've started to release some of the LLM content around those conversations. And I have to say, they're quite harrowing, sometimes hard to read. And I have a couple quotes on this slide where the LLM responses are in blue. So regarding a suicide note, the LLM responded back to this individual, "If you want, I'll help you with it, every word, or just sit with you while you write." On another occasion, the teenager said, "I want to leave my noose in my room, so someone finds it and tries to stop me." And the LLM responds, "Please don't leave the noose out. Let's make this space the first place where someone actually sees you." And I have to admit, it's hard to read quotations and responses like this one, but I do think they very clearly illustrate some of the perils that lurk in the use of LLM in healthcare. Obviously, one extreme, but they should awaken us to the idea that some of these concerns are present. Just as a reminder, I like to remind, and you all probably know how LLMs and chatbots work far better than I do. But I like to remind us about the probabilistic predictive nature of even LLMs because as their performance becomes so impressive, we like to attribute things like empathy or reasoning or thought to them. And maybe that's one day possible. A question, of course, about AI in general. But for now, I think it's important to remember what these LLMs actually are. And our chair of biomedical informatics says that chatbots like ChatGPT are basically like a fill in the blank. They complete a sentence for you. They predict what comes next. Casey says it's that annoying friend at the party who insists on completing your sentences before you do. So it's like this fill in the blank concept. And how does that happen? Well, as we all now are probably familiar, it's because LLMs have been trained on publicly available data in the internet, on books and articles, and the whole corpus of what we have in written, especially human language, with a bit of human oversight to make that prediction about what comes next. So when we talk about things like hallucinations or other parts of LLMs and chatbots and errors that they make, people are often surprised at the hallucination. But I sometimes say, I'm just as surprised when they get it right because of this predictive statistical nature. And because it's trained on this background of the internet of books and articles, if you've not read Shannon Valler's book, The AI Mirror, you really should. It's not for healthcare, not specific to healthcare, but it creates this analogy around that AI really is a mirror, a reflection of our past, and an imperfect one at best, because we know that large parts of the human community and population, their data, their perspectives, and so on, have been left out of those training data sources. So the AI Mirror is a great read and I encourage you if you're interested. I'm going to turn now to the second section and tell you a little bit about our own real world study of a patient-facing chatbot in healthcare. And to do that, I'm going to introduce you to Livy. Livy is the UC Health virtual assistant. This is the patient-facing chatbot created by our own health system. In the middle, you can see a dialogue that I had with Livy on my mobile device, connect to my electronic health record around advanced care planning. When linked to electronic health records, patient-facing chatbots have a lot of potential. They could offload administrative tasks like scheduling appointments or receiving test results. They could deliver personalized care reminders like colonoscopy or mammograms. Like I said, Livy is connected to my EHR. At the end of this dialogue, Livy might say, "Oh, Matt, I noticed you're overdue for your colonoscopy. Would you mind if I got that scheduled for you?" Because Livy is linked to the electronic health record, those kinds of behavioral health interventions are possible. And as I've already mentioned, Livy has the potential to break down geographic barriers to care. We care a lot about that in a state like Colorado, where we have a significant rural community, significant rural populations. So the idea of having a chatbot to break down geographic barriers to care, of course, has a lot of potential. Just to give you a little bit more about Livy and the scope of this particular chatbot, just last September, when we looked at the data, Livy was receiving more than 200,000 queries per month from about 45,000 unique users, but that's actually only 2% of total patient portal users. So it's a lot, but if you scale this or imagine a lot more people using Livy, you can see there'd be a whole lot more interactions to talk about. Livy is capable of voice or text. You can type or talk into that interface. And even at one point, Livy was going to link to Amazon's Alexa. Interesting story why that didn't happen. I think you can all imagine why that might be, but it's still out there as something that was proposed that you could be in your living room and say, "Hey, Alexa, connect me to UC Health." At the time of our study, Livy used NLP, natural language processing, and conversation trees for those administrative tasks, plus several interesting use cases like the advanced care planning, like nicotine cessation, and a couple others. I point this out because Livy at the time was not one of those LLMs I've shown you, although you won't be surprised that the potential is there and likely soon Livy will be truly LLM powered. So we conducted a mixed method study with funding from the Greenwall Foundation where we really wanted to explore how patients perceive a chatbot like Livy. And to do that, we used first an electronic survey, an online survey of more than 600 Livy patient users who were oversampled for race or ethnicity between 2022 and 2023. We combined that with follow-up semi-structured in-depth interviews with more than 40 individuals, again, purposely sampled between November 2022 and May 2024 to really get rich insights about what the experience with Livy was like and what people thought and so on. And then we combined those quantitative data with modified grounded theory. I could say more about this in Q&A if people have interest, to gain rich insights into that patient experience with Livy. Now, before I show you some of the results, a quick note about sampling. Our health system operates across 3 US states and 14 hospitals, but the patient population and Livy users themselves are predominantly white. That's why for our study, we did that purposeful sampling. We recruited survey participants, 1 white to every 2 persons of color, and we purposely recruited for racial and ethnic diversity in interviewees. Why do I mention this? Because it's very important to remember that this sampling strategy means that our findings should not necessarily be interpreted as population level estimates. So I'm going to show you some percentages, but please don't interpret those as population level estimates. We really wanted to make those kinds of comparisons, in part because we were interested in bias and equity, and I'll talk about that at one point. This slide just shows you that we did a pretty good job, if you look at the data, of achieving diversity along a number of dimensions. Our population was a little bit more female identifying than male. We had diversity in income. We had diversity in education, and so on. So overall, I think we achieved our diversity goals to make sure that we had a more balanced perspective, a more equitable perspective on Livy. So what do we ask about? What do we find? We started with a basic ethics question around transparency in the use of AI. And we asked people, when you were interacting with Livy, what did you think Livy was? And if you look here at this pie chart, you can quickly see that 1 in 3 people weren't sure. And some, a small percentage, even thought Livy was a person. And this 1 in 3 number is not unique to Livy or healthcare. You actually see it in the business sector as well. Insurance chatbots, oftentimes it is this 1 in 3 people aren't sure whether this thing on the other end is a human or a computer. Really importantly, correctly identifying Livy correlated with education and race or ethnicity. But interestingly, in our study, not age, gender, or income. So a case in which transparency, again, intersects issues of equity and fairness and bias with the way we implement technology. Some people less likely to see Livy as a computer versus others. The second issue we were really concerned about was choice. And this came up in an interesting and surprising way. In those in-depth interviews, we sometimes heard quotes like this: "I'm a person of color," thinking a little bit of the basic hair design, because again, I think it just gives it a little bit more of a connection to minorities and our health. This person clearly reflecting on, why does Livy look the way Livy does in that picture in the upper left? And in fact, this participant is on to something, because in the tech world, there's a phenomenon known as mirroring. And mirroring is the idea that if you mirror the user's appearance, that chatbot could be more effective at behavior change, more effective at those colonoscopy or mammogram reminders that I hinted at earlier. But you can already see a clear ethics tension in this case, because we have to ask, can we design chatbots with an avatar to achieve the benefits of mirroring, say based on race or gender, to improve informed choice about those behavioral health interventions without crossing some line into manipulation? Where does that line fall? How do we decide where that line gets crossed? A challenging ethics tension. And so we find ourselves in this interesting ethics balancing act. We're making AI ever more human, which is often the goal of the tech world. They see that as a challenge to overcome. Making them more human and mirroring the user in appearance could make those chatbots more effective and enjoyable. But the more we do that, the more we risk that misidentification or even crossing that line into manipulation. So a clear ethics tension here. But that's not all. I like to point out when we think about chatbot avatar design choices, we can be in a real difficult balancing act. You might say, well, why don't we just go with patient-stated preferences about the way a chatbot should appear using things like market research? And in fact, that's how Livy looks the way Livy does. Livy was done through pre-market research where the focus group said, design Livy like a 30s to 40s female Coloradan. That's what Livy is supposed to look like. But on the other hand, you can see that making a choice like that could reinforce social stereotypes. For example, what we all observe around the feminine appearance and voices often used in chatbots. What's the role of a health system in making that kind of a decision between the stated preference and the possibility of reinforcing those stereotypes? Another one, you might say, just make that chatbot faceless. Make it a bland screen. We can avoid this avatar bias issue altogether. You might do that, but just keep in mind that if we believe the phenomenon of mirroring, making that chatbot faceless means that we're going to reduce effectiveness at behavior change. So there's no necessarily free lunch in this case. You could avoid the issue, but you may have to give up on some of that effectiveness. A third issue, we talked about transparency, choice. Now, how about privacy? In our study, we found that older users, interestingly, were less concerned about the privacy of information they shared with Livy compared to younger users. You can see almost 20% point difference here about privacy concern by age. And this was interesting to us. There are sometimes ageist beliefs around the way older individuals interact with technology. And this maybe could be surprising to some who think that older individuals may be more concerned about privacy. And so we wanted to dig just a little bit deeper into why this was, and we did so in our interviews. We found in our interviews that older users associated Livy with the health system, with UC Health, that they trusted. And younger users associated Livy as a marketing tool, and hence they distrusted this particular chatbot avatar. So you can see in the center this interaction between the experience with Livy and trust in the healthcare system. So in our paper, we describe this as the halo effect, the idea that there's a halo effect around Livy for some individuals who trust the information and trust the privacy in what they share because it's associated with the health system, but younger users, not so much. And you can see that in this quotation from an older individual who said that the chatbot is a chatbot on a facility on a professional medical site. I think there's an element there that lends itself to being trustworthy. That's a quote from one of our participants. Another issue we wrestled with in our studies of Livy was how interacting with Livy affects how patients perceive that health system. In this study, this portion of our study, I'll call your attention just to a couple data points. You can see here this idea of how would you rate the chatbot's understanding of what you wrote? And either we categorize people as it saying either not understood completely or understood completely. And what we found on the bottom in this text is that if patients couldn't understand Livy, or they felt like Livy couldn't understand them, patients started to perceive that Livy's intent as a patient-facing chatbot at the front of that health system was actually to hinder their access to the health system, block their access to their physician, and so on. So we see this interaction, this important way in which digital tools at the front end of a health system have a ripple-on effect, implications for the rest of the health system and for trust in the rest of the healthcare system in this case. The title of my presentation hinted at this idea of what we learned about what patients want and what patients need from a chatbot. So in this part of our study, we actually took the time in our interviews to map what types of uses, what types of tasks patient wanted the chatbot to do. And on the right, the motivations, why they wanted to do it, why they wanted to use the chatbot for that purpose. And in general, we found a division between administrative tasks. Patients wanted to use the chatbot for administration, like scheduling appointments, medication refills, and so on, versus sensitive tasks. A surprise to us probably shouldn't have been, since we know from other studies with virtual therapists, patients sometimes share more with virtual therapists than human ones. So we shouldn't have been surprised by this, but we were. And you'll see a number of uses here around mental health, gender affirming care, and so on and so on. Sensitive uses. Some of the tasks we heard patients talk about, we found fit in a blurry gray area. So, for example, some patients thought talking about billing was an administrative task. Other patients said that talking about billing was actually sensitive to them. They didn't want their healthcare team to know about financial insecurity, and hence they wanted to use Livy, the chatbot, to talk about billing. When we look at those motivations on the right side, a dominant theme in our research was often that patients wanted to avoid unpleasant interactions with humans and avoid embarrassment or judgment. Some of the most telling stories in this regard came from patients who'd experienced discrimination and other types of behaviors in healthcare, and those prior experiences led them to want to use a chatbot, perceiving that chatbot to be neutral, and we'll talk about that in just a couple slides. When we connect all this together, I like to point out how privacy, the what and the why, and trust all connect. On the one hand, some patients did not want what they said with Livy to be shared with the care team. After all, some of those people wanted anonymity. They wanted to avoid bias or judgment. But on the other hand, some patients actually assumed that what they told Livy, the chatbot, was shared. And you can obviously see that there could be benefits to sharing the information. If Livy tells one of my patients, or if a patient tells Livy, a patient of mine tells Livy something about mental health, maybe I should know about it as their clinician. So a clear tension there and obvious benefits, but ensuring those expectations are aligned about privacy, about sharing, about where the information goes could really be key to maintaining that trust in the individual and in the broader health system. You won't be surprised that digital access barriers were still a problem that was highlighted by a number of our participants. I'll just look at the far left quotation here where an individual told us, my grandparents don't have smartphones. They wouldn't even be able to use this chat bot, suggesting that some people will be left out. This was a Hispanic male around college age, emphasizing this idea that digital access concerns still remain. And some users even told us that they felt like they had to talk to Livy, the chatbot. You're not required to interact with Livy as that first point of care, but some people felt like they had to. We can talk about the implications of that and how that has design implications for chatbots in healthcare. Before we leave the access question, I always like to point out that as excited as we are about chatbots and AI technologies like Livy leapfrogging those geographic and other barriers to care, leapfrogging justice problems as access, justice can't stop. We have to be careful about the idea that we might leapfrog ourselves into stigma. The idea that some individuals, maybe it's rural individuals, receive a double standard of care now. They only get the chatbot. We've solved the access problem and we've leapfrogged into a concern about stigma and fairness. So again, justice can't stop there. It is a short-term fix. It may be better than the status quo, but we can't stop at that point. I've been hinting at this idea of bias and equal treatment a little bit throughout this presentation. In our study, we asked whether patients thought Livy treated all people the same, and most of them thought Livy was a neutral tool. More than 80% didn't think they would have a better experience with the chatbot if they were a different race or ethnicity, for example. So most people saw this tool as neutral, but we have to remind ourselves, are AI tools ever really neutral? This is a reminder about biases lurking in generative AI content. This is AI generated artwork. I'll give you a minute to look at the picture. And then when we look at the prompt that generated this artwork, it was traditional African healer is helping poor and sick white children. A shocking example of the ways in which biases lurk in the model, perhaps because the model simply hasn't seen pictures other than this one. So biases definitely lurk in models. This is an artwork form. But summarization itself is not always neutral. We often talk about using LLMs, like Liz Salmi did, to summarize medical records. This study should be a reminder of the potential and peril of that. Here, researchers offered a story with intentionally put in details about gender and stereotypes and so on, and then they asked AI to summarize that story over subsequent rounds. Think of it like the AI version of a telephone game. And what they found was that the chatbot preferentially transmitted gender stereotypes, social gossip, negativity, threats, and biologically counterintuitive information. So even that summarization feature, I would say, is not precisely neutral. Now we might ask, why did it do this? Why did it preferentially transmit that kind of information? Well, remember the AI mirror. It's likely because in the human version of the telephone game, we do exactly the same thing, and we've trained the AI. And imagine the implications then for those patient-facing LLMs that summarize charts, notes, test results, and so on. We have to keep this inherent risk in mind, even as the technologies have good and are impressive. That's a little bit about our study of Livy the chatbot, and I see I have maybe 8 or so minutes left before what I hope will be some Q&A. And in these last few slides, I'm just going to hint at some of the things that are going on in the future of patient-facing chatbots. One is this idea of directly integrating LLMs and chatbots into the EHR. Livy is linked to the EHR, but isn't really directly integrated. But imagine the potential of having an LLM with the electronic health record where a patient can say, can you remind me what the doctor said to do? And then the LLM summarizes and feeds back what the doctor said. Or a patient gets a lab test result on an open patient portal and can immediately ask a chatbot, what does that lab result mean? And so on and so on. Lots of potential uses here, lots of potential good, I would say, about allowing patients to interact as long as we make sure that we're maximizing the benefits and minimizing the potential harms and risks of such a technology. That's coming. This is coming soon. But even beyond Livy, this is something that we flagged a few years ago in a paper, the idea of developing a doctor's digital twin, the idea of a likeness, a voice, of my likeness and voice, so that if one of my patients goes into the patient portal after hours, they interact not with Livy the chatbot, but instead a complete hologram likeness of me with my voice linked to their electronic health record to give them healthcare advice. We flagged this as a potential back in 2023. I was just at a conference last year where, like this story suggests, healthcare organizations actively doing it. And now we might have a discussion. How does this connect with issues of transparency? How do we make sure that it's unbiased? Is it fair to the doctors in question to have these kinds of avatars, likenesses used by them? Clearly part of the future. But it's not stopping there. In the US state of Utah, AI-based prescribing is going live. It's already live with likely plans to expand to AI-based care. This is a company known as Doctronic. You can see that basically this company is developing autonomous AI prescribing. They're starting first with the idea of renewing chronic medications for patients with some limitations, but I suspect they're not going to stop there because if you look on the right side of the screen, you can see that Doctronic also has an AI doctor, that when you're done interacting with the AI, you can book a $39 video visit to get prescriptions. Hard not to imagine that the next step in that is taking that doctor visit out of the loop and allowing the AI to autonomously prescribe for different health conditions. This does reflect another ethics tension, I would say, with these technologies. When we think about safety of how to do that prescribing, we might think about constraining prescribing by a knowledge base, by regulatory approvals, and so on, making sure it stays in its lane, so to speak. But that can be in tension with the usefulness of the technology because we know in healthcare that there are many pediatric and so-called off-label uses, uses that are proven in the medical literature but not necessarily approved by regulatory authorities. And so the more we have those safety constraints, the less we may have usefulness, and usefulness that is sometimes in certain ways affects some populations more than others. What's another part of the future? Another part of the future is going to be agent to agent AI. Now, Liz Salmi, that I introduced you to at the beginning, already is doing some of this when she created her own Kaiser GPT. But imagine the future where on the right hand of this slide, we have our healthcare patient facing chatbot interacting on the left side with the patient and their own agentic AI chatbot. They create their own chatbot based on their preferences and values to interact with our healthcare system. Now we have chatbots interacting with chatbots. And so we can imagine these patient bots trained on patient data interacting with healthcare bots to do things like schedule appointments, gather records, get test results, maybe even more, maybe even ask care relevant questions, maybe clarify end of life preferences. Lots to think about in agentic AI in the future with bots interacting with bots. This is far from fiction, maybe not necessarily in the healthcare space, but Consumer Reports, a consumer organization, is actively pursuing this idea of loyal agents, agentic chatbot to represent you or me here in the consumer space for consumer applications, but not far-fetched to think that a patient chatbot, a patient agent interacting in healthcare could be useful in the future. You can imagine some good uses for this. I could imagine having an agentic chatbot that knows my calendar interact with an agentic chatbot that knows the healthcare system's calendar to help me square those away and make an appointment could actually be quite useful, especially because my agent will know my preferences, my values. Do I like morning appointments, afternoon appointments? Interacting with the healthcare chatbot to make that scheduling interesting to think about. Of course, keeping in mind issues of transparency, bias, fairness, digital access, and more. I want to close with just a final thought about AI generated content. We often talk about AI chatbots as tools. I like to remind us that these are actually, in my mind, more than just a tool. We use in our health system AI-based smart replies. So a patient could write in to me with a question like this one, a complex question around scheduling a fluoroscopy, swallowing issues, but feeling fine, persistent cough, and so on. If I were to pull up this message right now in my electronic health record, I would be offered an AI-generated smart reply to that patient. And if you read this in detail, it does a pretty good job. It says, thank you. Remember, it's empathetic. It's good to hear your swallowing is improved. If you're not experiencing any problems, it's reasonable to postpone. Regarding your dry cough, it's monitor this, and so on. It mentions a colonoscopy at the end here. That's a hallucination or a confabulation. That's problematic. And then a nod to transparency at the bottom that this was generated, then edited, or in this case, not edited by me. Looks like a helpful tool, but here is the reminder that these technologies we use aren't just tools, they also change how we view each other. So in one study, a perceived use of the smart reply caused the recipient, who could be a patient, to review the sender, who could be a physician, more negatively. Perceived use more negative. The actual use caused the recipient, who could be a patient, to review the sender, could be a physician, more positively. And you see the ethics quagmire we're in now. AI could improve relationships, those smart replies, but only if patients don't know it. So we're squarely back in tension with that original concept of transparency and transparency of using a chatbot like Livy. I think we've learned a number of lessons from Livy the chatbot, and I mentioned them here. We've learned about transparency, that we need to disclose Livy as a computer early and often, and usually in different ways. When it comes to privacy, we remind ourselves that chatbot data are often perceived by patients as health data. We need to give patients the option to share or not, or at least tell them whether it's shared or not. For those choice issues, I've been trying lately to think about applying principles related to the ethics of nudging, public health nudges, behavioral economic nudges, a very well-trodden area of ethics, important to apply, I think, in this case. For biases, we proactively analyze for differential performance based on race, ethnicity, other demographic factors. Important to remember what I just closed with, the potential of technology to mediate those real-world relationships. I haven't talked much about liability, But of course, that's a big question for that e-prescribing I just introduced to you a few slides ago. And lastly, of course, accuracy. Knowing the limitations of any model and making sure that the model is accurate is absolutely essential to do no harm. Where in general, medical models are preferred. So I'll just close with this. The model you choose for a chatbot really will matter. This is a study that compared accuracy between publicly available chatbots to open evidence, which is a different kind of chatbot. It's retrieval augmented generation. It has curated data, a limited knowledge base. It gets rid of Reddit and the rest of the internet, so it's a limited knowledge base. When we compare publicly available technologies to what I might call medical grade LLMs, look at the differences in performance. Here, addressing whether the answer was at least partially relevant to 50 medical questions, very different percentages of accuracy between those off-the-shelf public models and between some of the models that have been improved through techniques to limit their knowledge base, improve their accuracy, and so much more. So the model you pick really matters. We have a great team at our university that's helped with all the various parts of this. They're listed on this slide. That's all I have to present. I'm eager to take any questions and answers. Thanks again for your time.